Good evening, everyone. Welcome to today's CME session for this end of month of April. My name is Dr. Idza. I will be your host for today. With me today is not going to be a presentation. This is going to be a talk, a candid talk about Phaco in Kenya. I know we've heard a lot about the fluidics and the machine and the Phaco and the complications, but all that, what is the situation in Kenya? For those of us who are practicing in Kenya, want to know if we are going to transition, what are we looking at? And if we are doing, what are we doing that we can improve? What are we doing that we can incorporate other ideas and knowledge to better our practices and skills? So Dr. Frederick Korir, our OSK chair, is going to moderate today's discussion. Kindly, if you have any questions, put them on the chat box. We shall be able to respond to them either during the discussion or at the end. Our speakers or panelists are going to be Dr. Godfrey Nyaga, Dr. Mukiri Mukuria, Dr. Jyoti Trivedi, and Dr. Joseph Nyamori. Dr. Korir will introduce them shortly as we start. Please remember to mute your mic as you join so that we do not interrupt the discussion as it goes on. Dr. Korir, karibu sana. Thank you.
Thank you very much, Dr. Kalu. And as you correctly said, that today is just a conversation that we're going to have so that, we kind of, wrap up this discussion about Phaco. So the last two sessions we've had was a lot of academics, a lot of videos on what to do, but there are realities that we have to, have a conversation around and hopefully, develop ideas in which, we can help ourselves transition. So I'm going to invite some of the panelists that Dr. Kalu had said. I'll start with Dr. Jyoti to just introduce herself and say hi. And then after her, we'll go to Dr. Mukiri. Dr. Jyoti.
To myself. Thank everyone. I'm Dr. Jyoti, a Fico surgeon, cataract and a refractive surgeon, working as a consultant ophthalmologist, as medical director with Dr. Agarwal's Eye Hospital.
Thank you, Dr. Jyoti. Dr. Mukiri.
Good evening, everyone. You'll forgive me, my network is a bit unstable. I work at the University of Nairobi as a lecturer, and I've also been trained as a cornea and anterior segment specialist.
Thank you. I'll have Dr. Nyamori and then Dr. Nyaga to finish.
Hi, everybody.
Hi, Dr. Nyamori. We can't see your video. Good.
Yeah, there I am. So my name is Dr. Nyamori. I'm a lecturer at University of Nairobi, retina specialist, but as well as doing cataract surgery, trained at LV Prasad, and I'll be proud and I'm happy to be with you today. Thank you.
Thank you, Dr. Nyamori. And finally, Dr. Nyaga. Dr. Godfrey Nyaga. Dr. Nyaga, we can't hear you.
Seems to be muted. I don't know.
Yeah.
Hello, can you hear me now?
Yes, now we can hear.
Oh, sorry about that. So I'm saying I'm Dr. Godfrey Nyaga, consultant ophthalmologist, practicing in Nairobi, retired from a lot of active public service. Now I'm doing private and farming. So I'm trained in Kenya, and I didn't go abroad for those fancy things. Me, I'm locally made, and I train in the trenches. Thank you.
Thank you very much, Dr. Nyaga. And that is one of the reasons why we invited you, you know, with your lots of experience, and all these panelists have been handpicked because of the value that they add into this discussion. So since you're online, Dr. Nyaga, let me just ask you what your view is in terms of, you know, M6 that has been, and now we are seeing transition into Phaco. What are the benefits of M6 compared to Phaco, and what do you think Phaco brings in? Yes.
Okay, I think if we are to go down to the nitty-gritty, the right now, and honestly, the only benefit of M6 compared to Phaco is mainly the cost. The cost is cheaper to the doctor in terms of setup and to the patient in terms of the surgery. But you will find that patients now are demanding for Phaco. Patients, you have children who are bringing their grandmothers to Nairobi to be operated, and they have gone through the internet and they come and ask to nataka hiyo ya machine. So it is very embarrassing. Sometimes you have to refer a patient that you could have made good money off, but because you can't do Phaco. But as I say that, I will be honest, because I've worked in the Ministry of Health, I've worked in mission hospitals in private, and it is not easy. It is easier said than done, but Phaco has been, it is very expensive to set it up. And anyway, as we discuss more, all these things will come out. But the main advantage is the cost, and that a local surgeon in Kisii or in Mandera can be able to do a 6 with very basic things, but microscope is key.
Thank you. Thank you very much, Dr. Nyaga, for highlighting all that, mainly cost, and, you know, people, anywhere you are, you can do M6. Dr. Mukiri, what do you think are the benefits of Phaco now that it's coming in? What is it going to add in? And Dr. Mukiri.
Yes, I think I would like to echo what Dr. Nyaga said.
Yes.
Phaco, if you are good at M6, the outcomes will be basically the same. I don't know if my internet is good.
Yes, we can hear you very well.
Benefits of Phaco probably is maybe a shorter recovery time. Patients don't have so much discomfort post-op, especially if somebody is done under topical. The incision is smaller, and probably when the patient hears those tinging sounds of the machine, they feel like they have really been operated, as opposed to other things. So, but as Dr. Nyaga said, people are demanding for Phaco, so you have to move with the times, and I think also less astigmatism post-op because of the smaller wound. I think those are some of the benefits of Phaco over small incision.
Yes. Thank you very much, Dr. Mukiri, highlighting those benefits. I know we've had several debates in, you know, some of the, you know, COEXA conferences, OSK conferences, a big debate about M6 versus Phaco, which one is better. But what do you think is, sometimes I wonder, what is M6 here to stay? Do you think we are ever going to say now we're never going to do M6? Is Phaco the next big thing? So maybe the first question is if I am a surgeon and I don't want to do Phaco, is that okay? Is M6 going to stay here and be with us? Second question is Phaco going to be, you know, one of those things you must have when you're finishing your residency or something in like the next 5 years? I throw this question to Dr. Jyoti. What do you foresee in the future? M6, Phaco, Dr. Jyoti?
Yeah, I saw it. I heard you. The first question of yours is whether the small incision cataract surgery will stay back or not. Yes, definitely yes. As long as we are the developing country, it will definitely stay back because of the cost reasons, as per Dr. Nyaga said. The second thing is that patient expectations, patient education levels have gone high up, and they know what is Phaco, what is small incision, what are we doing and what not. As far as I'm concerned, most of the patients are knowing even what are the types of the IOLs which we use here. So the thing is basically that yes, small incision will stay as long as we are the developing world. But I think in the future, for future to see, definitely yes, Phaco will be the main thing for us. Phaco will come in, and I feel that the Phaco should be introduced for the University of the Nairobi students, so that it can be in the learning curve of them as well. So I feel that definitely Phaco will come within the next 1 decade. Yes, definitely yes, Phaco will be the one thing.
Thank you very much. I think that sets a good tone for this conversation. You know, M6 is still a very good, I'm just trying to summarize. M6 is here. It's still a very good and useful tool. It's cost effective, but now we're seeing a lot of demand for Phaco. A lot of us right now are doing M6. These questions goes to, again, to Dr. Nyamori, and then maybe Dr. Jyoti, you can add in terms of what do we, as a surgeon, who is an M6 surgeons, you know, what do we need to consider when transitioning at this period to, you know, Phaco? You know, basically, what are the things that can help me transition smoothly from being an M6 surgeon to a Phaco at this point of time, if I'm doing a lot of M6? Maybe Dr. Nyamori, you can go, and then Dr. Jyoti can add in.
Well, thank you very much for the opportunity. Well, to answer the question on what are the basic requirements to transition to Phaco, as a learner, I think.
Dr. Nyamori, I think we lost you. Dr. Nyamori? I think we can get back to Dr. Nyamori when he comes back online. Maybe Dr. Jyoti, you can take the question.
Yeah, if you are a very nice and very good small incision cataract surgeon, I think it will be very, very easy to transit. But there are some of the basic things which you'd like to know. That one is that you need to know your Phaco machine. You need to know your settings of the Phaco machines. That is very important. So you need to learn about the machine, and then you need to learn the skills, how to use. Because in Phaco, you are going to use 2 hands, 2 legs, both the feet you are going to use, as well as you are going to use both the hands. So you are supposed to get used to that. And the main thing, what they need to know when they are doing small incision is capsular access. Their capsular access should be absolutely perfect. If they are learning it on small incision, it will be easy for the transition into the Phaco. There are quite a number of points, you know, because we have lost Dr. Nyamori. I think I will just continue until he comes back. Okay, Dr. Nyamori, you can continue, please, then.
Okay. Yeah, sorry, you just got a blackout when I was speaking. Now I'm on bundles. Sorry for that.
Oh,
yeah,
sorry.
I think, thank you, Dr. Jyoti, for the quick thinking and rescue. So in addition to what Dr. Jyoti has said, of course, we can never underplay the role of a small incision before we go to Phaco, because it's only through small incision that even you can practice the capsulorhexis to the level of confidence, so that it's not a variable when you're doing a Phaco. I tell people, for you to just do Phaco, make sure you can do a very good CCC. In fact, after you're there, it will be easier than doing a small incision. Once you're a good small incision surgeon, you cannot worry so much about the Phaco, except from the familiarity with the machine and the fluidics. The other advantage would be when you are a learner in Phaco and you get a complication that makes you not to abandon the Phaco, you will definitely need to fall back to the small incision. That is why we can't take it for granted that forever the small incision is the primary skill.
Dr. Nyamori, again, it's gone off. I think Dr. Nyamori, Dr. Jyoti.
Okay, I will continue with for Dr. Nyamori, what he was saying, that yes, I agree with him totally, that whenever you get even the mildest complication with the Phaco will have a severest problems post-operatively. So the rescue factor for us is the small incision. Actually, small incision, even if it gives you maybe 612 or 69, patient will be still happy rather than going again, continuing with the Phaco when you have a complication initially, when initial stages. But as you get better and better, I think with Phaco also you can learn how to deal with the complication with the smaller wounds. But I think a small incision will be a very good rescue for those people who are transitioning in the beginning period of their change towards Phaco.
Okay, thank you very much, Dr. Jyoti. Dr. Nyamori, any other final additions?
Yeah, no, thank you. Sorry for that again, the hiccup. But I think Dr. Jyoti has captured the most important aspects. I think from there, it will just need now practice, and familiarity to the different Phaco machines. And then it should be fine once you've done a small incision.
Thank you. Yes, I think those are very good pointers. The fact that you know small incision, you actually know the feel of you know, how the eye is. And I think it makes it easier for you. It should give you more confidence that if anything goes wrong, I'm able to have a fallback. It gives you a cushion. And I just want to reiterate what Dr. Jyoti has said in terms of getting used to or using all your limbs, you know, your left leg, right leg, left hand, right hand. I would also encourage people to even small things like brushing your teeth using your left hand so that you know how, you know, your left hand feels. Basically start wearing that left hand with your brain. Dr. Nyaga, I think this next question goes to you, and I'd like to encourage the people who are online to also ask questions as we go, so that I can, you know, add. But I have a few guiding questions to take us through in the meantime. Dr. Nyaga, you know, as somebody is trying to transition from M6 to Phaco, I know you probably went through that, and I think Dr. Mukiri also will join in and answer this question after you. My question is, what is the commonest complication that you would encounter as you transition, so that some of the people who are going to be transitioning really watch out for those, so that, you know, they have a smoother transition? What would you say would be some of the maybe top 3 or the complications that you can think about, so that, you know, they look up on the management? Dr. Nyaga.
Thank you, Dr. Correa. I think the first or the main complication that all of us, when we are beginning, will normally get is we normally say it's like a drop nucleus. You just think, okay, this cataract, let me Phaco. You just hit that, hit the foot pedal. You discover you are with the nucleus and it has gone, gone. Okay, because you have not understood properly about the positioning, first, second, third, suction, Phaco. So before you even know what is happening, especially if you make a mistake of trying a hard cataract, so that is the main complication is a drop nucleus, and that is why everybody will be telling you, make sure your Phaco machine can also do vitrectomy. Number 2 is you chewing the iris. Okay, you are entering with the probe, and before you know, you have already started stepping. And the main thing actually is the positioning of the feet, as you said, Dr. Coril, the knowing how to use your hand and your foot at the same time. So you are not sure the water is supposed to be irrigating so that the AC doesn't collapse. Before you discover, you're already starting to Phaco and you chew the iris. Number 3 is eating your capsulorhexis. You've done a good CCC, you just go, you are grooving, chua, capsulorhexis is gone. Those are the 3 top complications for me.
Thank you very much, Dr. Nyaga. Yeah, I'm laughing because those are the things that really happen. What would you advise somebody to do, you know, to avoid pushing the nucleus, chewing these things that you're talking at the iris, the capsule? What would be your one pearl to avoid it?
The main issue number one, make sure the pupil is well dilated. You have hydrodissection that made sure the nucleus is rotating, okay? And then master the foot pedal. You need to master it. Master the foot pedal, so that you know this is irrigation, this is suction, this is Phaco. If I see my AC is collapsing, what do I do? Even without removing the probe, you should, those dynamics, you should be able to do that. And also start, start grooving gently. Don't, okay, me, I was taught by a guy who used to do chop. So I think I dropped more nucleuses than the people who started grooving, but I think groove, be gentle and go for soft cataracts. But foot switch. That's what I can say.
Good pointers. Well-dilated pupil, maybe start with divide and conquer, which is grooving before you go to Fico chop and all these fancy techniques. Good points, Dr. Nyaga. Dr. Mukiri, anything else that you want to advise people? The commonest complication, how to avoid them?
For me, I think I've made all complications thinkable during Phaco. Starting from the size of the wound. Sometimes you just make the wound any size, and then you realize that the Phaco probe is much smaller than you actually made the wound. And you find that fluid is flowing out and your AC is collapsing and you're wondering why. Also, the opposite is that you make the wound too tight and you burn the wound for the putting in the Phaco probe. The second thing was when you are grooving, is that you groove, you're too aggressive. When grooving, that you go right through and you get a PC tear, or you punch a hole into the PC without knowing. So knowing that how much or how deep and how long should be the grooving is very important. Because mainly Phaco is to get rid of the nucleus, because cortical matter can always be sucked out, but the nucleus is what needs to be emulsified. So knowing the extent of how big the nucleus is of the cataract is what is key. Dropped nucleus, as Dr. Nyaga said, is also something if you're not careful. Also, zooming in too much. If you zoom in too much, you're not able to see the whole surgical area too well. So you might be concentrating too much on the site where the Phaco probe is, but you're not seeing that the wound is too wide open and your AC keeps on collapsing if you're not careful. And then also the dynamics of the machine is also important. So slowly by slowly, if you're good at your small incision, then your hands are very good at manipulating when you're in the eye with two instruments, as opposed to small incision when you mostly use one instrument in the eye. So it's a new ball game, and practice is very key. Having someone to stand by you in the initial stages is very key to point out these things which you may not notice initially. I think that's all that I had. Thank you.
Thank you, Dr. Mukiri, for that. And I like that last advice. You know, initial cases, have somebody with you. Sometimes things happen so fast. Sometimes you're focusing on your Phaco probe and your left hand is pushing on something and you're not watching. And you know, you can get a surprise. And so if you have a recording, if you're able to record, it's usually good, because sometimes you can replay it, and also you know, you're able to see things and improve your technique with times. I don't know whether I know this is a very interesting topic in terms of complication, what to do, what to avoid. I'd allow Dr. Nyamori, Dr. Jyoti to chip in if they have anything to add.
Okay.
So, yes, Nyamori, go ahead.
If I was to answer on the, Dr. Nyamori here, thank you. So if I was to answer on what will be my greatest top complications that I'll be concerned about, one is a poorly dilated pupil, which leads to what Dr. Nyaga has pointed out. We may end up with a floppy iris. It tends to come into the probe so many times, and by the time you're seeing the patient post-op, there's really iris atrophy and chafing, and you lost all the pigment. My second one that is of concern is sometimes the biometry is, you do biometry very well, but post-op you find you're really off when you do refractive status post-operative. Those post-operative surprises on the refractive error, that's a reality that has really always gets me concerned. And then of course the patients who have got loose zonules, sometimes when you don't dilate very well, you may not visualize that the bag is a bit floppy and gaping on one side. Then the vitreous may come out through the side when you're putting in your vacuum. If you're not careful, that patient becomes our patient, becomes a retina patient. So we need to anticipate. A very well dilated pupil might help to save you, to anticipate all the other problems that may be there. Thank you.
Dr. Nyamori, I'll just throw another question back to you. Yeah, you talked about those retina challenges that can happen when you're doing Phaco. You know, Dr. Nyagas mentioned about a nucleus drop, and now you mentioned about zonular dialysis somewhere and vitreous coming in. Do you think it is wise for somebody in, very far away with no vitreoretinal services nearby to just do Phaco? Can I do Phaco without vitreous backup, basically? Can I start Phaco if I'm in, I don't know, below or something like that?
Yeah, thank you for that question. I think, yes, you can, because luckily those cases are a bit rare, thankfully, such that on the side of probability, you are less likely to meet those kind of cases. But you can also anticipate some of them just when you're doing your case selection. The very old men who are on Flomax, it's called Flomax, tamsulosin, the prostate drug, you can anticipate, and almost for sure you'll find that floppy irises which are not dilating as predicted, and they're always coming into your Phaco probe. Those ones you can be careful maybe to do them last or when you've got a backup. So you can use some predictive factors on your case selection so that you don't end up, maybe when you're doing those ones on one day, you make sure there's retina around. But also, I would say we just have to do Phaco. The only thing is a well-dilated pupil tends to save you a lot of trouble because you can anticipate so many other things than a pupil that is not dilating well. Then when you go in, press your probe, once irrigation reaches, the whole bag and cataract and everything flies into the vitreous. It can be quite frustrating when it catches you off guard, especially when you have not seen it pre-op. The problem is you need to tell these factors to the patient and tell them you're going in, but the following might happen. Because if it happens and you didn't mention, these Phaco patients can be very fussy and they start blaming you like you're the one who did everything wrong. That's one thing I learned, is always to get all the risk factors and try to mention them before. That the challenges here will be as follows. We might change, we might put in a CTR, capsular tension ring, all that. The patients perform better post-op when you talk to them, when you had already prepared them psychologically. I think that's the one factor that you can see. Luckily for most of them, even if it happens in the periphery, you can patch that eye and refer to your nearest surgeon if the bad luck strikes too late.
Thank you. Thank you, Dr. Onyamori. Dr. Jyoti, on complications, yeah.
Yes, I think there is, if you Dr. Korir, take this as a separate topic, I think there will be quite a number of them complications for the Phaco as such. Mostly Dr. Nyaga, Mukiri, and Dr. Nyamori has said about the intra-op complications. I think post-operatively, initially you are going to find corneal edema. Let me tell you, that will be the first that complication. If you have gone through well with the Phaco, still you will get a corneal edema. The next day, maybe there is a corneal burn wound which you might be having. Sometimes a flat AC you might be having. That can be the post-operative complications for the cornea, as well as you might get a cystoid macular edema there if you stay for a very long time inside the eye. That is other thing which you can get. And I think refractive surprises, those are the ones which are very, 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 very difficult to handle post-operatively, and that because the Phaco patients have a lot of expectations from us and they know what they want from us, and that's the reason I think we will have problems. There is one intra-op I will just give you a practical. It's not written any in the books or something. It is my experience that whenever you are changing the irrigation bottle, I think you should not be inside the eye. If you are inside the eye and you are changing the irrigation bottle, the dynamics change a little bit and you might catch up on the posterior. And especially it will happen when you are removing the cortex when you're on the cortical mode, like the cortex removal. And that is the time I think there is a change of the bottle. And when you are doing the irrigation change in the bottle, dynamics will fall and you will cap at the posterior capture. So it might not be your intention. You might not be seeing, you are just concentrating that, oh, irrigation bottle is being changed. The other thing, when it is changed and whole of the bottle must have finished before, there might be air bubbles which are coming inside there, and these air bubbles might cause you a PCK or something like that. Choosing a patient when you are doing a transition for a Fico from small incision, choosing a patient is a very, very important thing for you.
Thank you, Dr. Jyoti, for all those comments. I'm just going to go through some of the comments that people are making while going through. Dr. Angela Mokaya says motorcyclists use both hands and feet, so they're saying she can hack the surgery. Dr. Sandia says Phaco is like riding a motorcycle. We need to be simultaneously concentrating on both on our hands and legs. Well presented. How do you deal with Argentinian flag signs starting and really progressing fast? I think that's a common complication with the intumescent cataracts. Maybe Dr. Nyaga, do you want to talk about a few tips on dealing with the Argentinian flag sign in white intumescent cataracts? How do you deal with it? And do you do Phaco for those?
Normally I say every cataract is Phacoable unless I'm unable to Phaco when I'm operating. For the Argentinian flag or for the very white cataracts, the first thing is, one, you need the heavy visco. Don't use the light visco for when you're doing the CCC, because if you use a light visco, then everything will go haywire. Number two is have a very small nick, and your AC needs to be almost leak tight. I don't know how to put it. And sometimes we say you can go in with your capsulotomy needle with a syringe and you poke and aspirate so that you decompress. But all these things are easier said than done. When you are in that eye, some, even as you'll try, it will go haywire. Others, it will do, you'll be able to manage. But also stain, by the way, with Vision Blue. Stain. Yeah, but heavy visco and a good microscope.
Thank you, Dr. Nyaga. Yeah, I think I totally agree. So many videos, so many things you do, but sometimes even the best of hands, it still runs out. How does a beginner select a good case for cataract surgery? For Phaco surgery. I know I think Nyamori has mentioned a few key things. Maybe Dr. Mukiri, just highlight some of the things you would, tell for me, if I'm beginning Phaco emulsification, being a small incision cataract surgery, what are the things I want to look out for an easy case in terms of, age of patient, kind of cataract, all those kind of things? What would you look at as the pointers? Dr. Mukiri.
Well, for a beginner, one of the things is probably you may not select the case yourself. Probably someone can select for you from experience, knowing what you would expect to go through during the surgery. But one of the key things is, one, as people has mentioned before, one, that the pupil dilates very well, very wide dilating pupil. Second, the cataract is not too soft and not too hard. Maybe a nucleus of N2 will be ideal, because one of the first ways of techniques is how to trench, and you want something that you can feel there is a good trench that can be formed. A very soft cataract, you can't trench very well and you can't crack very well. So it'll be very frustrating to operate on such a cataract. So something that you can trench and you can rotate and follow just the basic steps which you had gone through in the previous. And then also now don't go for complicated cataracts or cataracts that have high IOPs or previous intraocular inflammation, stable zonules, and also maybe one that you can stain the cataract so that you can actually see the capsule, see the edges of the capsulotomy very well, and you can know the limits of how far to go during your trenching. I think that's what I have.
Thank you, Dr. Mukiri. I think I'll add you want a patient who doesn't have a very large or deep socket, prominent brow. But depending on which side that you're operating on, I would say maybe the temporal. I prefer the temporal, Phaco, temporal Phaco as opposed to superiorly because of just the easiness of handling the probe. I'd like to reiterate something that Dr. Jyoti mentioned. That was the cornea edema. As people transition, you tend to use a lot of Phaco energy, which is not good for your cornea. So you want to be in the iris plane whenever you're doing Phaco to keep away that energy. Use as little energy as possible. Secondly, the other thing we tend to forget about what gives you an edema is just how much fluid runs through the eye. If you use 2 bottles in a case, there's such a rapid changeover, you'll stress the endothelial cells. So those are the 2 things that happen. And you want to assess the patient and make sure that they do not have guttata. You just do retroillumination, look at the endothelium, just to make sure that they do not have Fuchs dystrophy or anything. Because these patients some of the patients that you end up doing Phaco will decompensate. Luckily, we can do DSEC in some of these patients later. I just wanted to add that case because that is another more common complication that we'll probably see. One other thing that we haven't had a conversation about is just the IOLs. Maybe we mentioned it, but as a small incision surgeon, we're used to this very big rigid lens whenever we're doing surgery, and sometimes you can put it anywhere. Half the time you don't know whether it's in the bag or it's in the sulcus. Where is it? Where are you putting it? But when you're doing Phaco, I think it's important to know how to handle the lens, a foldable lens. There are so many of them, and you kind of have to practice with each new lens that you're using. Maybe some comments on lenses. Every time you have a Phaco patient, they tell you, okay, doctor, which lens are you going to put? And I don't know, I personally find it a very difficult conversation to have with the patient. What are your experiences? Let me throw this to Dr. Jyoti and Dr. Jyoti first, and then Dr. Nyamori, in terms of IOLs challenges and patient selecting the IOLs basically, and the complication thereof.
Dr. Corey, thank you so much. You rightly said that it's very important to know about the IOLs. I think if you give me a chance another time, I think I can give a whole highlights on the IOLs, which are in the market at the moment and which are being used all over the places. As I told you, the patient expectations are high and the patient knows about the IOL. They even know about the A constant. Some of my patients know even the A constant, which we don't know sometimes. So there are quite a number of IOLs, and when we are doing a small incision cataract surgery, we are just knowing a hard PMMA lens, maybe with the holes, without the holes, and that is what we were used to. Later on, we got an aquafold. Then there are aspheric lenses. You see, there are quite a number of these things. But I'll come to the premium IOLs for the Phaco because you will get quite a number of patients who are asking for the premium IOLs, and you will get a refractive IOLs or diffractive IOLs in that. So you might get initially when the Restore started, that is the Alcon people started, it was, I don't have any financial interest with any of this IOLs, but I'm just giving you the examples. So Acrisoft started Restore in 2005. And actually the multifocal started in 1990s basically, but 2005 Restore started with a +4. So +4 was giving a quite a big amount of an hyperopia when stress biopic corrections for the people. So people started tending to use, that both eyes when you are operating. Later on in 2007, they introduced +3 for the Restore IOL, and then we could put one eye +3. I used to do that, and another eye +4, so that could compensate for the other eye for the vision purposes. Then we got some of them are trifocal lenses. We are even having some quadrifocal lenses at the moment. There is a panoply which has come for the Restore. There was a crystal lens which was there, which was very nice as well, which had come in 2005. And the crystal lens went into evolution 2005, 2007, 2008, 2009, like that. 3 years it was in evolution, and it really got a good this thing for the extended depth for the patients like that. So trifocals were being used that time. Now we have gotten a quadrifocal because of I'll tell you one reason for that is that when you do a bifocal lens like previous Restore lenses, which was for far and the near vision, the patient would come to you and tell you that I cannot see my food to eat because your food is at a kitchen distance that is 40 centimeters, and you couldn't get the 40 centimeter distance for that patient for eating the food. So he had to put the plate a little bit nearer for him or her for them to eat. And then I realized that there is something a problem with these lenses, that where if we put it, then eating is a problem, or something which a kitchen stuff is a problem, or the computers. Nowadays we are using a lot of computers and all that, so you need the intermediate focus as well for that. There's some people who you have to be very, very careful in putting the multifocal IOLs. Is one is teachers, interior designers, architects and engineers, which are using fine lines to do that. So you need to know what you want, what they expect from you. So that is how the IOLs should be changed and should be given. I do quite a lot of counseling for the IOLs for my patients. I do quite a number of high-end IOLs. So that is why I'm asking Dr. Corey that one chance, if he can give me another time, I can discuss about the premium IOLs or the IOLs per se in depth for each and every IOL, and how to convince the patient or how to counsel the patient. Too much of an information will cause a confusion to the patient, and too little information will cause you problems later on if at all you don't give them what will be the effects or the side effects or little bit of the effects post multifocal IOLs. So I just put it in the brief, all these things for you today.
Thank you, Dr. Joshi. I see you're very loaded. We will definitely give you a session on those IOLs. Maybe Dr. Nyamori, just anything, just a few things, just a few additions on the IOLs, please.
Yes, thank you, Dr. Corey and Dr. Joichi. Yeah, Dr. Joichi has covered it's actually a big topic on its own. You can talk and talk forever for the premium IOLs, but in principle, is what I will say, always discuss in a concise manner before the surgery about the IOLs than after, because you can put a mono on a patient, then later on they meet the neighbor who was done multi, they come back telling you, well, how come you didn't tell me that I could have put this on? Yet you had judged them and thought maybe they couldn't have afforded the other lens. So in all these Phacos, I will say information that you give is better given earlier than pre-op than post-op. It tends to save you a lot of trouble. By the time someone wants these premium lenses, remember their personality already, they've got high demand. And a high demand person is also very easy to get frustrated and also to frustrate you, because if they don't get what they were expecting, it will become trouble for you. So this is a premium patients. I think, as she says, you need a specific talk about them and how to choose. And also very perfectionist personalities, of course. You have to be very careful when they're coming to you for multifocals, because they're the same ones who, after surgery, they're even telling you they're 6'5" and they're still telling you just remove this lens now. Okay? There are very interesting things about the human factors that start coming into play. The more and more they start demanding premium lenses, be careful that post-op you'll have some interesting curves in the discussion after that. Thank you.
Thank you very much, Dr. Nyamori. I'd like to bring the discussion back a little bit to the superficial level. I think we've dove very deep into Phaco. I want us to come back a little bit about training in Phaco in Kenya. you know, we are talking about Phaco, we've been having these lectures, but what do you think, maybe I'll talk, this one can be Dr. Nyaga and Dr. Mukiri. Dr. Nyaga can go first. In terms of, you know, our local ophthalmologists, you know, do we really have to go abroad to start learning some of these things? What would you advise, you know, people who are able to train, or how do we go about, you know, training and making sure us as ophthalmologists, we transition into doing Phaco? How can we go about it, Dr. Nyaga? Suggestions?
Thanks a lot, Dr. Coril. And I think for me, when I look at when we trained and how things are now, things are a little bit different, because during our time, I think as it was a time of hardship, where even when you got posted, when you were posted to a government facility, even to get a microscope that you could have binocular vision was an issue. You used to operate almost like on monocular cues. For training, the first thing we have already said, these people have to do a lot of SICS. But now here you are a registrar at the University of Nairobi, and all of you, from the consultant to the CEO, all of you are fighting over those 2 cases in the theater list. So there is no way that this person will be able to get their hands on. I feel the university or the people who are selling Phaco machines or people who are selling IOLs, there's a gap here that we need to feel, like having a proper wet lab where somebody can come, practice before they hit before they go and start doing it on the patient. Number 2, these Phaco machines, somebody needs to have a feel. They need to touch, not just see a machine that is normally, our time, the machine used to be somewhere you're told that was for just Dr. Khan. Sorry if you're in this meeting, Dr. Khan, I apologize. But there was a machine that you could not touch even to dream. You just look at it from afar. Let this patient, let the young ophthalmologists, let them have a feel so that we demystify. And I say, the more people learn Phaco, I cannot Phaco myself. If I get a cataract, or if my dad gets a cataract, that ophthalmologist, wherever they are, that is the primary doctor who will be able to sort out your parent or my parent. It is in our interest for all of these people to learn. At the university, we need to also demystify cataract issues. Don't scare people about vitreous and everything. I think we need a different approach. That is my suggestion.
Thank you very much. Dr. Mukiri, any addition on training? You're in the university, maybe you can answer some of those questions.
Well, some questions I will purposely not answer, but it is a very good question, because as the society is demanding for Phaco, then even the training should actually be ahead of what the society is demanding. So we should be able to anticipate in terms of training, what are the needs of the society, and be one step ahead. So Phaco in itself, for it should be accessible to majority of patients, and that means the cost of the equipment and the consumables should also come down. One of the things I've seen in some other centers is that people buy, or they are given maybe a Phaco machine probably, and they're able to pay for it slowly. And when a new machine comes up, they can trade in and get an upgraded one. So that is one marketing tool that can be used by people who sell the Phaco machines, and so that this thing can be accessible to at least the big institutions or people who are interested in it, so that they can, especially training institutions where people who are going to leave have experienced it, and once they leave, they would want to continue using that skill they have learned. And of course, once they get there, they will also demand they will think of getting the machine as well. So that is one way of getting everyone to get hold of a Phaco and train and continue using it. So there's no need of training, and then you go to the field and there's nothing. I remember one of the first times when I wanted to do Phaco or training Phaco, I was told you pay so much, what the figure. And not only that, you come with the patients. You go and look for patients who are willing to pay the Phaco, and you come and do it under our supervision, and you also pay the institution. So it was quite hard for me even to train locally under those circumstances. So maybe a different approach, as Dr. Nyaga said, is the way to go. Thank you.
Thank you, Dr. Mukiri.
Dr. Gore, if I can speak in between, if you don't mind, for the training.
Yes, go ahead.
Okay. Yeah, I would suggest that we can have some wet lab, if we can do the wet labs actually initially for the people who are going to do this for transition trainings. I think it will be much, much better. The second thing is that observing the Phacos is also a main thing. If you observe a Phaco surgeon doing the Phaco, you will be able to get some nicks and do's and the don'ts when the surgeon is operating. I think the observership is very important. If you see in the developed world, quite a number of people go for just observership. They can observe the things and they will be able to do some of the things with the transition becomes quite easier. Wet lab was my dream, actually a dream project since a very long time. I have been approaching Dr. Agarwal's actually in this audit meeting, which I had just 2 weeks ago. I have told them that we can put up a wet lab so that I can cater for some of the students who can come over and can learn the Phaco from me, do observership also. Even now, I wouldn't mind them coming to observe into the theater for seeing the Phacos whenever I am operating. So that will ease up for them, that stress which they get when they start working with 2 hands and 2 feet, it becomes very difficult. So the transition, as far as Dr. Mukiri is saying about the training from these centers and getting, like you get trained and then you don't get the machine. So I think there should be a public-private partnership as well in this case, which has been in our Kenya National Strategic Plan, which was there in 2020-2025. And I think if we have the public-private partnership, then it will be easier for the students to train from the University of Nairobi into the private sectors as well, where there will be more Phacos and all those things. Though the thing is that if you don't are having the camp patients or something, then it is very difficult to give a real patient. That is why I was suggesting that we should go ahead with a wet lab first, so that once they train on the wet lab, then it is easy for them to get their own patient or to get your patient to show them how they are doing and you are there on the side for them to just to help them out initially if they are doing something or what is happening.
Thank you, Dr. Jyoti. I hope many people are listening in and many are decision makers, and those are some of the suggestions. We're running out of time. This is a very interesting topic. We cannot finish everything. I'll just quickly run through some of the questions that have been coming, and then we wind up. I'll have them answered, and then all of you can give me a little parting shot, and then we finish. I had missed Dr. Situma's question. What is the most affordable, yes, useful machine in the market? Does anybody want to take that up? Maybe Dr. Nyaga, you're the one who's been in the field for very long. What do you think would be the most affordable Phaco machine? What are they? I mean, you can list them.
Okay, I don't know whether I was the right person to do that, but I will still answer. Okay. Like us, when we started training or when we started doing Phaco, the main people who would supply machines were Alcon. And Alcon could even place a machine, but they would hit you with the consumables, okay? So for example, let me give you an example of a machine called Laureate. It was a very good Phaco machine, but the consumables disappeared. So you have a machine, but the consumables have disappeared because they want to introduce a higher grade of machine. So you are at the mercy of these people. Now, currently, the machine that I'm using currently at the 2 centers where I go to, the theaters that I use, they are using the Oatley Machine. And I think there is somebody locally who is promoting Oatley. Okay, also no financial interest, but it is a portable small machine which you can sterilize the cassettes. So you are able to bring the costs down, but the initial cost of the cassette is high. So most of the centers that you will find, for example, like you, Dr. Koril, who's operating in a hospital that has some element of charity, you will be souvenired an old machine from somewhere. And when you're a beggar, you can't choose. Whatever you get, you use. But personally, I feel either people need to come together and a pool of guys, for example, people from Western, you buy a machine and place it somewhere and all of you can access it. But if you just want to go and buy a machine for yourself, for you to use, if it is not a high volume machine, then your Phaco becomes very expensive. Yeah, that's my take.
Okay, thank you, Dr. Nyaga. Some of the comments, Dr. Mashep said, beginners may also get rexes run away from overfilling the AC with viscod, zonular dialysis from 2 small rexes with rotation of the bag rather than the nucleus. Conjunctival swelling if your wound is too posterior in the cornea, and also affecting poor visibility, that can cause poor visibility. Dr. Nandasaba had asked a question, I think, which has been partly answered. What are the challenges we are faced in setting up a Phaco training centers here in Kenya, and how can we overcome it? I think Dr. Nyaga has mentioned some of those. We've answered those questions in somehow. Dr. Gokle says it is important not to get carried away by our ego when we have a brown or black cataract. Doing a 6 would be more endothelial friendly than fighting with a black cataract. So sometimes our ego, we don't want to get the money and eat the big rocky cataract. Dr. Momanyi says, I would also like to advise beginner surgeons to stay within the central safe zone and not to chase the nucleus fragments with the Phaco needle. So basically your Phaco tip should try to be in the center as much as possible. Don't go to the periphery with it. You'll eat the iris, you'll eat the capsule, as he said. Sometimes you can puncture the posterior capsule. Dr. Kareko says pupil expanders come in handy in poorly dilating pupils. So there are these pupil expanders, iris hooks. There are some which there are several methods, and I think you can use it in poorly expanding pupils and also in these patients with Flomax, floppy irises. So those are very handy. Some patients who get multifocal IOLs get halos post-ops. How do you deal with this? This is from Dr. Munira. Maybe Dr. Nyamuri, you can answer that. How do you deal with the halos from multifocal IOLs post-op? Is there a solution?
Okay, thank you, Dr. Yeah, thank you, Dr. Correa. Let's answer it briefly. First, you must explain preoperatively, as I said, to these multifocal patients. I repeat again, pre-op explanation becomes very important, that they're going to get halos. Then when they do have them post-operative, they'll handle them better, but you also tell them, generally you'll find that the complaint is for the first 3 to 6 months. After that, most of the patients, they realize they are good to go with it because there's something called brain adaptation. The brain adapts to those small imperfections with your new normal. Now you tell them that will be your new normal, but after 6 months, you'll not even think about it. It's a crisis immediately after surgery, the first 3. For those who linger on, maybe 6 months. Most patients get out of it. If it's too much, sometimes you tell them maybe when they're driving at night, they use anti-glare spectacles. But you know what? The most important thing is that you tell them they just get used to it. But you start telling them this from before is more important than telling them on the first day post-op so that they're not surprised. I think I've seen it's not a big deal most of the time when you reassure them. Then by the 3rd visit, 3rd month, they tell you, it's good, I'm happy with the way it is. It tends to work.
All right, thank you, Dr. Nyamori. Dr. Nabasaba asks, what is your take on the using beginner simulators to learn Phaco versus wet lab? Is it worth the setting it up for teaching a Phaco? Maybe Dr. Jyoti, you can take this. Simulators for training versus a wet lab.
The simulators, yes, I can agree with that, but it is very expensive. It will be very costly for the students or the ophthalmologist who want to do the transition. Initially the wet lab, and then if at all it is a possibility that we can set up the simulator lab, it will be much more easier. So simulators are all over in the developed worlds, all over the places they are. But for us to get a simulator and start doing on it, it is very, very expensive. It is very, very expensive. I have inquired about it before even thinking about the wet lab, whether we could do the simulator labs but it is quite expensive. For actually the person who is getting trained will pay for it. So it will be very expensive just to get the Phaco training.
Thank you, Dr. Jyoti. Dr. Nyamori, maybe you can help us with the last question. What are your suggestions for beginner settings for Phaco? Vacuum, Phaco 1, 2, 3. If you want to type it down, it's okay. But if you want to say, go ahead.
Wow. Okay. Thank you very much. But that really depends on the machine. For example, now I'll just give you the one for the Accuracy because that's the oldest machine I think we are having in the market. There are many other machines, so I will not advise that we cram for one particular machine, but maybe the issue is to whether low or high, okay? So when you're doing during phacoemulsification itself, of course, the vacuum is slightly lower than when you're doing the irrigation aspiration. That's in principle. When you're doing IA, the vacuum usually goes up and the Phaco power goes 0. When you're starting with Phaco for Accuracy, I think power 40 tends to be within a very good, modest power to work with for most cataracts. Don't increase. Once you go above 40, you'll start increasing your risk of Phaco burn. The other thing, when your probe is in the Phaco wound, watch the needle that it should be in the center of the Phaco sleeve. When you are doing very high powers and the Phaco sleeve is on one side of that rubber tubing when it's on your wound, you will tend to increase even the risk of Phaco burn. Then if the power is higher, don't do continuous Phaco. Don't step on your pedal continuously like accelerating a car. Step in pulses to give it a moment for that probe to cool in between your Phaco steps. Don't press on it continuously. Maybe in a pulsed mode or keep taking breaks. It as you break your step so that the hard cataracts don't end up with a lot of Phaco burns. Then water height is usually 65 centimeters. But as we said, as the earlier presenter said in the last 2 weeks, it varies with what you're getting. Because if you've done a very big paracentesis or a big wound, then it's leaking. Then now you might have to compensate for that extreme leak with a higher bottle height. So it has to really go with feel, but the normal settings are water 65, Phaco power about 40, and then vacuum usually 300. Don't put very high vacuum when you're starting. You better start low, then increase the vacuum as you've tested your step. Then you put 400 when you step, you've eaten everything, now you don't know where you are, your iris is gone. There's no time to go back. Better start low for vacuum and then go higher. Then, of course, when you do IA, the vacuum tends to shoot up to about 400 automatically because that's the time now you want to suck out everything. But I guess some things are while you're there, you tailor it to your needs. But those are the common settings. Water 65. Yes. Hello?
Thank you.
Yes.
Thank you, Dr. Manyamori. I'll just, last question. Dr. Sitati asked that she has observed that in multifocal IOLs, after like 3 to 4 years, they start to shift. She's asking whether the design of the multifocal IOLs has changed to accommodate for this. And as this causes a change of refractive errors every 3 to 6 months, that's disturbing to the patient. Does the lens moving around, have they changed the design to accommodate for this shift that she's talking about?
I don't think so, but shifting of multifocal IOL is a reality that for as long as you put them, even month 1 post-op, you can get it. The idea is when you're positioning it, put the haptics up and down than across, because when you put the haptics across, you'll find the centermost ring has descended below the level of the pupil. So you have to put your haptics superior and inferior. I'm assuming when you say multifocal that the diffractive, refractive, the ones with rings. Remember, there are many others Dr. Joiti will tell us about, because each specific multifocal will have those challenges. But the ones with the rings, forever, the decentration is a reality. You have to be ready to take charge. I've had to take patients back to just dial them back. But try to dial them back within the first 1 month. When you're saying 6 months, it might have formed fibrosis, then you can't spin that lens, it'll be tricky. But to prevent that, make sure the uptick is 6 o'clock and to 12 o'clock and 6 o'clock, so that the up-down shift is not there. Of course, you might get a bit of a sideways, especially in very large eyes. That can be a challenge, but the multifocal lens itself is not the main factor. It's a huge, for example, a huge eye, then you feel like the lens is dancing inside, that can be a factor. The other thing is your rexes should not be too large, because the optics might pop out of the bag and then you have a tilt. So you have to really know the exact, not too small, of course, because of capsular phimosis, and not too large that the rim, outer rim of the optic pops out of the bag. So it's the rexes that will be the most important thing, and positioning of the haptics, rather than we blame the IOL itself for the diffractive, refractive ringed ones. Thank you.
Thank you, Dr. Nyamori. I think I had wanted us to do a parting shot, but I think time is really, really not on our side. Thank you very much, all the panelists. I think you've done justice to the topic. We've had conversations, and you can see that there's so much that we can talk about in Phaco. Perhaps we can have more sessions in the near future. Dr. Jyoti has volunteered to talk about IOLs. So thank you everyone for listening. I want to hand over to Dr. Kalu. I think we have a sponsor who has something to present. So kindly please stay online. Just let's listen to what they have to say. Dr. Kalu.
Thank you, Dr. Korir. Thank you, Dr. Jyoti, Dr. Nyaga, Dr. Nyamori, and Dr. Mukiri. That was quite an awesome presentation. We've learned a lot, and I think it's just the start. We should have many more of these discussions and answer even the small questions that maybe perhaps someone has sat on that question thinking, this one is not, we are discussing this and mine is very simple, but answers to each and every one of them. I'm going to invite Musyoka, who is the representative for our sponsor today. We are being sponsored by Dawa, and Orolab company. And so please keep around and don't go away yet for the next at least 5 minutes. We have them give us a talk, then we will wind up. Thank you. Musyoka?
Yes. Good afternoon. My name is Tobias Musyoka.
Yes.
From Dawa Life Sciences, who are the sponsors for this webinar. Like we have been doing even the year last year, but now today my project manager is traveling. He had prepared some slides, at least so that we can be able also to participate in this conference, but due to some circumstances that he's not able to share the slides with us. But he has promised to do that next week when he's in a position to do that. So Dawa Life Sciences, like we told you last year, because I remember last year we sponsored about 2 conferences through the same organization. We are very happy to be participating in these kind of webinars with you. And we will continue sponsoring some more webinars to come. What I will request you is that we will continue supporting our products. We have several products. Dawa Life Sciences is one-stop shop for eye drops. And we also have some blades, drapes, hydrocular lenses like the PMMA, sclerofixated lenses. But as I've said, we are not going to show you at the moment. Next week, my product manager will be able to share the slides yet prepared. But still on the field, we'll continue visiting you, myself and my reps, in your clinics, the hospitals you do work. And I hope and I request that you continue supporting Dawa Life Sciences. Thank you so much.
Thank you, Tobias. Thank you for keeping it short. We shall be waiting to be reminded more about your products. Ladies and gentlemen, we have come to the end of our CME today. Thank you for giving us your time and being present and keeping time. Sorry, we have extended our time by 9 minutes. We pray that you have forgiven us for that. But we hope that you have enjoyed the discussion. Thank you for all the panelists. Thank you, Dr. Koriri, for moderating. We are going to give you more information on the next CME on our WhatsApp group. And that's it for me. So have a good evening, everyone. Eid ul-Fitri for our Muslim friends and the rest of us, those who are going to cry for a late president, we shall be with you in spirit. Those who are using this as a resting weekend, enjoy your weekend, and let's meet here again. Time and date will be communicated in due course. Have a good night. Bye.
Bye-bye. Thank you.